Okay, so we're gonna get into diuretics. So I just want to give a full warning. This one is gonna be the monster chapter relating to a little bit of a complicated. It's gonna get a little complicated, but I'm gonna do my best to explain it because once you understand what's going on in the kidney, you will actually be able to understand what's happening everywhere else, and then that makes everything way easier and it clicks way better, and then you start remembering everything. So thankfully, with the help of Paris, look at this. Wow, look at that! I can actually write on the screen now. So we're gonna use that. We're going to use that to our advantage because it's going to be super important to for us to actually understand what's occurring, right? So I'm just going to give this a little message, right? Hello. And then hopefully we have some good luck on this one. All right. So let's get right to it. So kidney structure, right? I'm going to skip this because we should know that by now. Renal regulation, right? For the most part, I want you guys to know that there's fluid volume, right? We control fluid volume, we control electrolytes, acid base balance. To make things way easier to remember what the kidneys do, I have added this saying, a wet bed. This helps us out understand everything: acid base balance, waste removal, electrolyte control, toxin, blood pressure control. Erythropoietin, I want you guys to see that one because that one's new. We've seen these other ones before, but erythropoietin is a little bit more of a unique thing because erythropoietin is remember what we made our little signal thing where it has like a relay and stuff, and that's what that is. This is what erythropoietin is. That is our signal to create red blood cells, right? So erythropoietin points to the liver, right? We have the liver. We'll say this is the liver, and then it will make the liver create RBCs, right? So it helps create. The liver has the pieces to the puzzle, but the erythropoietin is the one running the show, saying, "Hey, I want you to actually make red blood cells," right? And then this is a review from way earlier in the semester where the kidneys are the last step for making vitamin D turn into calcitriol. So calcitriol helps us just absorb more calcium, right? And then here it is, right? Here's our here's everything right here, right? So erythropoietin mediates red blood cell production. Calcitriol turns vitamin D into its active form in order to get calcium. And this is the extra one, but this has a lot to do with this right here, blood pressure control, right? And I did add an additional picture to help everybody understand the renin aldosterone, or I'm sorry, the renin angiotensin aldosterone system, because that is going to be very important for our ACE inhibitors, our ARBs, and for what is going on. And I will explain it as well, but I provided a picture that I think gave a pretty good review of what's going on in terms of blood pressure management. So now we could get into the actual kidney, right? So we have the nephron, right? That is the actual functional unit of our kidney, right? It's what's actually filtrating, right? I did my best to make the connections with the highlights. Look, glomerulus, proximal tubule, which is going to be everything right here. This is our proximal tubule. Our loop of Henle is everything right here. This is what our loop of Henle is. And then our distal tubule is everything right here and going on right here before you actually get into the collecting duct. And this goes straight into this right here. And then it goes straight into the bladder by the ureters, right? So that's the process of urine, right? Blood enters through here, it makes its way here, and then comes through this arterial, goes through the glomerulus, gets filtered, goes into the tubule, the proximal one, goes down, goes into the loop, goes in the distal, makes sense, right? Proximal, distal, goes right there, and then it goes straight down into our collecting duct, which is all right here. It goes down the ureter, goes into the bladder, and then we pee it out, right? So that's just our connections that we're going to make for this one right here. Moving down, right? This is where things are going to be a little bit more complicated because now we're having things like reabsorption and secretion. It's very important to know the meaning between both. I want you guys to know reabsorption, right? We're talking about reabsorption. I want you guys, here's our blood vessel, right? Look at that blood vessel, it's all red. Reabsorption means it's going, because this is our nephron, right? The yellow is our nephron, the red is our blood vessel. Reabsorption means it's going from the blood vessel, from the nephron, right? And it's going to the blood vessel. That's all it is. Secretion means it's going from the blood vessel to the nephron, right? Think secretion as depositing. Think reabsorption as a refund. Think of it that way. That's going to be a way to help out, right? Additional things that I want you guys to know about. And I did my best to annotate little notes right here, right? Most of the water we reabsorb in our body normally occurs in the proximal tubule. This is where most of our water comes in. And look, these pictures are very helpful. I had these during physio when I was doing my prereqs, and they really helped me understand, right? So here's where most of our water reabsorption occurs, right here. This little block right here, I sectioned it off to help everybody understand. And this right here is where we collect water, or we reabsorb water from. And the majority of it is here. Most of our sodium starts piling up right here, right? Because this is just where osmolarity comes in, right? We remember osmolarity is relating to tonicity, right? If we have a high level of tonicity, that's as close as we get to actually being concentrated solute than a solute being in solvent. And a solute is something that is that can't be diluted in water as easily, right? Like it has to be, it's kind of separate from water, and it's suspended in the water and it becomes part of a solution, which is called a solvent. So to put a connection, right? Um, Imagine in your head a water bottle, and imagine you have food coloring. The water bottle is your solution, your food coloring is your solute. And as you squeeze a little bit of food coloring in the bottle, now it won't be clear, it'll look a little pink, but it's still transparent. Now, what happens if you squeeze a lot of solute? What if now you have a big giant bucket of food coloring and you dump it over that one little bottle of water? Now it's all going to be mostly solute. So yeah, it's oversaturated. It's highly concentrated. This is the same idea that we're doing here, right? Because our osmolarity right here, as it's going in, because this is the filtrate that comes from the glomerulus, it goes straight down. And as it's going down, notice how the osmolarity, right? If something has a higher osmolarity, that means that the concentration is getting stronger and it's going up. That is another way of saying we're not as diluted anymore. We're actually more concentrated, which is why we said it. So this is as close as you get to like actually being having salt, like straight up salt, not salt in water, but like actual salt in our kidneys, right? So that's what we're gonna go with that. Please, please, please rewatch the video as much as possible. Watch videos online because it is so important to understand what's going on here. It at least helps me out if you can just if you try to memorize it just word for word 100%. Sometimes it won't help. If it does, that's by all means that's awesome, but I it helped me to understand how these diuretics work. So right, so our concentration of solute is going up as we go down, right? Look, we started at 300, now it's 600. So imagine it had 300 pieces of sodium, or like the magnetic, we'll use the word magnetic effect, right? We'll say magnetic activity because that's what helps me understand it better, right? So with water, we're at 300 points of magnetic activity. But look, now we're going down and we're now having water leave the tubule. The water is leaving the tubule and it's going back to the capillary into our blood. Now, as we're removing water, what did we say in our electrolyte chapter that hypertonic fluids do? They drive water to it, right? The magnetic pull, that we can say for water to go gets higher, right? So as we're having and the higher the tonicity, right? Look at that. Now it's 600. Now it's 800. Now it's 1000. Now it's 1200. The magnetic pole gets stronger the less water it has because it wants water. The desire for water goes up, so the magnetic pole goes up as well. Again, please rewatch this part because I know it could get complicated. Once we go past that, we're now at 1200 points for this to be in like our magnetic pole, right? From there, now sodium will eventually be reabsorbed. Look at this. These are all our arrows. Please ignore this for right now. But most of our sodium and most of our calcium are reabsorbed in the distal convoluted tubule. This is where most of our NaCl gets reabsorbed. Now, when it comes to reabsorption, right? When we take something, we also have to give something. There's not really a lot of situations in our body where we give without taking and we take without giving. So, a lot of times, in order to reabsorb this sodium chloride, usually under normal physiologic stuff, some potassium gets placed in here. Some potassium. Normally, we don't get hypokalemic on an average, on a daily basis, right? Because everything's working normal for us. But when a person has an alteration and is using something like a diuretic, this alters everything. But have you noticed how, look at this, right? So our tonicity got stronger as we were working our way down, right? All our sodium is here. But look, the moment our sodium starts to leave, look, the tonicity is starting to go down. Look, the pull is getting weaker. All of this is getting weaker. Now, it could be that we reabsorb too much sodium, or now we have a lot of urine created, right? Because we can either be hypotonic, right? Meaning low solutes. We can either be hypotonic because of overdilution of urine production, or we just really don't have that many solutes like sodium chloride, right? Now, that is how it goes in a normal nephron loop, like a normal passage of filtrate and then eventually urine out, right? To give a quick review, right? We have filtrate pass through here. It goes through the proximal tubule. Most of the water is reabsorbed in the proximal tubule. It goes into the capillary and it goes back into our bloodstream and we're good. We're hydrated, right? What is filtrate? Filtrate is just all the waste we have. And in that waste, we have sodium chloride. As we remove water from the filtrate in the proximal tubule, the tonicity starts getting higher because there's not as much water, right? All of this goes up because there's not that much water. It becomes very hypertonic. The moment you were to throw a little bit of water in there, it will suck it up because it wants water. The higher the tonicity, the higher the osmolarity, the higher the tonicity is, and the more desire for water, right? Look at this. It's going through. It starts to get at this moment right here on this little 3 right here. We start having sodium get reabsorbed in the distal tubule. When it is reabsorbed, now look at the tonicity. It went from 1200 to 1000. You're reabsorbing more sodium now. It's at 800. Now you're reabsorbing more sodium. Now it's 600, right? And then at the same time, urine is being collected as well. You're making urine and not just filtrate. And now that's helping with the overdilution, which makes the osmolarity go down. And then eventually it goes out, and now we have urine production. So what I want everyone to understand is that a, a loop diuretic specifically targets right here, the loop of Henle. And I will refer back to this when we get there, but just I want you to know the earlier sodium is prevented from leaving here, the more urine you're going to make. Would you make a lot of urine over here? Probably not, right? Because it's working late. Because at this point, look at how much sodium you really have. You don't have a lot. While you have a lot of sodium right here, and that sodium is going to pull a lot of water into here. That's why urine production will be very high in the loop of Henle if you use a loop diuretic in comparison to a thiazide diuretic that works more in the distal tubules. Okay, so now we're going to move on. Renal failure, right? So renal failure is regarding just the loss of, it's basically an alteration to all this. If you want to know what renal failure affects, just remember a wet bed. It will affect your ability to create erythropoietin. In fact, a lot of patients who have end-stage renal disease are anemic because they can't make red blood cells because their erythropoietin is off. It's super low. That's why you'll find a lot of patients with a diuretic with end-stage renal disease who are on dialysis. They will typically be taking some kind of erythropoietin drug. Also, vitamin D would probably be good to take because again, or active vitamin D. Right. So drugs can accumulate in high levels, right? Because what was one of our things from a wet bed? Waste, toxins, right? So drugs can accumulate. The longer they stay in the blood circulation, the higher the chance for toxicity, right? That's what we need to be careful with. Giving an average dose to a person with renal failure can prove to be fatal, right? Because the the person has increased time of that drug in circulation. So a lot of times when we've seen in our drug guides, it says patients with renal might need a dose adjustment because again, they can't take too much of the dose because they remove the drug less, right? And if they remove it less, it stays in our blood. And there we go. Now you have toxicity. Diagnosis of renal failure, right? I added our creatinine per our book. This is what it is, 0.6 to 1.2. It's a pretty low number. It's supposed to be. Creatinine is just our proteins that are found. Typically, they could come from the heart. They can come from a lot of different muscles, organs as well. So if your creatinine is up, that could point to issues with your kidneys as well. Urinalysis, right? Urinalysis. I don't know if anyone has ever done a traditional urinalysis test where they had to use like this long strip that has like a bunch of little squares in the middle, and as you dip it in urine, it makes a color, right? That one can show signs of past use of cannabis. That one can show protein in urine. If you have protein in urine, that is also indicative of renal failure as well. Diagnostic imaging is probably going to be your best bet, right? Because it's imaging. A biopsy as well. Definitely a biopsy will give you a for sure answer. And then a glomerular filtration rate, right? So what is that? What is glomerular filtration rate? That's just how much blood is going through the glomerulus in 1 minute, right? That's going through everything, right? That's all it is. And on average, typically it should be more than 90 mLs per minute. Um, People who have different stages of renal disease will have certain parameters, but if I recall right, end-stage renal disease is when your kidneys are only filtering 15 mLs of fluid in 1 minute. So that's really low. Acute renal failure, right? For the most part, look at all these connections, right? Look at this: hemorrhage, dysrhythmia, heart failure. These three things have to do with some kind of cardiovascular thing going on, right? Dysrhythmias electrically, heart failure mechanically, and hemorrhage in supply of blood, right? And I did my best to put little explanations that I didn't look into it too much, but this is just me rationalizing why these situations can cause acute renal failure, right? Dehydration, hemorrhage, these are both hypovolemia. There's low amounts of fluids that is causing damage in one way because our kidneys constantly need a steady flow. Just like how the heart happens to fuel itself, right, with our coronary arteries. Right as soon as blood gets pushed out from the left ventricle into the aorta, it gets put into that whole circulation with the coronary arteries. So I'm imagining that's where this is coming in, right? Chronic renal failure, right? This is that long term stuff. So, chronic illnesses lead to CKD. I would imagine diabetes mellitus would lead to CKD because we talked about what filtrate is, right? If we have high levels of blood sugar, right? Have you ever seen like a very thick fluid, like where like it's not really water anymore, it's like kind of more paste? That's what I imagine in my head when we have very high blood sugar, right? As it's passing through the glomerulus, which kind of looks like two hands kind of put together, like if you're praying. That glomerulus is our natural filter. The viscosity, and we already talked about it before with diabetes, right? Diabetes causes a lot of problems with our blood vessels as they are. The nephron loop has a bunch of blood vessels as well, so that causes issues, right? So the thicker the blood is, right, the more problems are going to lead to that nephron. Hypertension, on the other hand, too. Imagine you guys seen the glomerulus, right? It's this thing, right? Imagine there's higher pressure constantly hitting it for 24/7, 365 for like a good amount of your life. How much can this little organ take until it starts breaking apart or it starts getting damaged? At some point it's gonna break. Like it when is a question, but will it break? More than likely it will. If it doesn't, then you're made out of metal or something, because that doesn't usually happen, right? Drugs that can cause nephrotoxicity, we've talked about them. Acetaminophen causes damage to the liver, but also by association the kidney. NSAIDs as well, right? I highlighted these three different things. We don't even need to memorize all these different things, right? Because if we do a little bit of mental review from all our anti-infective drug chapters, anti-infectives are hell on the kidneys, right? Remember, amphicitosin. Remember our mycins. It is a sin to give a myosin because it causes liver damage. That's where that's coming from, right? ACE inhibitors. That one messes with the kidneys, and we will get into that because of the renin-angiotensin cycle. We'll get into that from there, but it's messing with it one way or another. If you're messing with it, it's gonna cause some kind of damage to the kidney, right? Because this one will affect the kidneys one way or another. And then radiographic IV contrast drugs, they cause a lot of damage. We had that one drug that we give PO that helps with IV contrast. That was the acetylcysteine, that PO drug that's supposed to be also mucomist, the inhaled drug. That one helps out with this. So, pharmacotherapy, right, are different types of diuretics. This is what's occurring. Diuretics are supposed to help us out in making urine, right? When our body, if our kidneys aren't really working, then they're not going to be making urine, right? And then it gets backed up. And then eventually now you have end stage renal disease, right? And then now you're really not making any urine. And then at that point you're dependent on dialysis. The only real way to get rid of the fluids you give or you take, I'm sorry, is you have to remove them by dialysis. That's the only real way you do it. So typically, you're going to be given, patients are going to be on a diuretic, right? We also want to lower hypertension because you want to minimize the damage that is going on to the heart with the heart failure, right? Because too much fluid will make the heart work harder. Because now it's like this game, this teeter-totter game, right? It's this thing of like this constant balance that it wants to have where the heart is working hard to overcome that high blood pressure. So as the pressure rises, your heart has to work harder too. But as your heart works harder, your pressure rises as well. So it's now this, like, again, it's this balance that won't ever really balance and cause a lot of problems. So that's why cardiovascular drugs are given, because they help control blood pressure. And if you control blood pressure, you lower the damage going to that glomerulus that we were talking about earlier, right? Dietary management. These are things that your patients might need to know. One thing I know when it comes to freaking kidney damage is that things that are supposed to go out don't go out, and things that are supposed to stay in go basically go out. They don't stay in, right? Protein is not supposed to be um, like you urinate protein. You're not supposed to be having protein in your urine. So you should be on protein restriction, because those free floating proteins can cause damage, and they cause more of a workload for the kidneys. The higher the workload, the more damage to the kidneys you get. Sodium restriction is specifically about lowering blood pressure, right? If we have a lot of sodium, we retain a lot of water. If we retain a lot of water, our blood pressure goes up. So if you were to prevent your blood pressure from going up, that's less pressure on the glomerulus and less workload overall. Um, Things like potassium, phosphorus, magnesium, your kidneys can't excrete them. So you need to be on restriction or have some kind of management. Management would be binders for these drugs. There's potassium binders, like our Kxalate, the ones that happen to help us poop out potassium. There's phosphorus binders. They also bind to phosphorus in food and help us poop phosphorus out. And I would imagine it's the same thing with magnesium as well. Blood glucose control. We also need to control blood glucose, because what did we talk about earlier? Blood glucose makes our blood thicker. If we make the blood thicker, the viscosity is high and the workload is high. So if we lower viscosity, we lower the amount of work that the kidneys have to do. Fluid restriction as well. If the patient isn't really making that much urine, would you want them to be taking 2, 3, 4 liters of water if they're not making urine? What's the only way they could really get water out in abundance rather than sweating or breathing? Urine production. So if they can't produce urine, they should be on fluid restriction. And INOs need to be monitored strictly for this type of stuff, because you don't want the patient to gain weight, and then eventually now you're having an electrolyte imbalance of some sort, right? So this right here, I mainly just made all the connections to the things that need to be corrected down here, right? We talked about it. Anemia gets fixed by these poetine. Look, I highlighted this part, right? Poetine alpha, poetine alpha. They're just replacements for erythropoietin. Hyperkalemia, here's that Kxalate, right? Or Kxalate, Pardomir. Removal of high levels of phosphorus, right? Phosphate binders. What happens when we typically have high levels of phosphate? We have low levels of calcium. So take additional calcium and fix that high level of phosphate. And then for hypervolemia, you want to be on dietary restriction of sodium. Use loop diuretics because they make the most urine. We'll get into that in a little bit. And then also use thiazide diuretics. And then for any metabolic acidosis, you give bicarb. Diuretics, right? So now we're getting into this, right? Now we're actually in the nitty gritty, funny enough. So they increase urine outflow, right? By some sort of chemical reaction using or what we can and what we can learn for our knowledge in chemistry a little bit, right? They're all going to typically have the same indications, right? Treatment of edema for all these different things. And the most recurrent ones are heart failure, liver failure, and chronic kidney disease or renal failure, right? Because those three different conditions cause high levels of fluid retention, right? So we need some kind of way to get rid of it by urinating it out, right? Here's our 5 different types of diuretics, right? The most common ones are thiazides, loop, and potassium sparing, and these osmotic and carbonic anhydrase are a little bit rarer, and they're very, very specific why they're given. So that we'll touch on a little piece, right? Biggest thing, most of these all have the same adverse effect. Dehydration makes sense because you're making a lot of urine, orthostatic hypotension because you just lost a lot of fluid, so your blood pressure goes down as well, and potassium and sodium imbalances. The biggest ones to watch out for those imbalances is loop and thiazide, but the most important one is loop because you make so much urine and you lose so much potassium in loop. You can with thiazides as well, but not as much with loop because loop will work earlier, like how we talked about, all the way in these pictures, all the way up here, right? The earlier you stop sodium from being reabsorbed over here, you're going to make more urine here than you would over here. And loops, again to review, loops affect the loop, funny enough, the name, haha, and then thiazides affect the distal tubule. Okay, so now we could actually go into this, right? Loop diuretics, right? They're the most effective diuretic. We already talked about this. They reduce edema related to all the 3 different diseases that we talked about. They block sodium reabsorption in the loop of Henle. We talked about that, um, right? It's given for acute heart failure. There it is again, right? And it helps make cardiac output and renal flow. It increases cardiac output because cardiac output is just when your heart can't really work hard anymore. And then renal flow, you increase it by helping out, basically do the kidney's job in a way, right, to make urine. Always check your potassium before giving. That is something we know, especially from Farm Lab. Has a long half-life, right? So probably watch out with kids, right? And especially like infants because they're developing, they require as much fluids as possible. Older adults may require lower doses, right? Especially with that history, possibly of renal disease, right? So, so here we have it, right? Here's our adverse effects: electrolyte imbalances, specifically hypokalemia. What happens if you lose too much fluids? You get dehydrated. What happens if you also lose too much fluids? Hypotension. This can make you have orthostatic hypotension, right? You stand up too fast, and now you pass out. And passing out has a very fancy name called syncope, right? So the nice thing is that they're all a little domino effect, right? One topples over and they all go across. The unique thing about Lasix furosemide is that it could cause ototoxicity, right? Now that transitions over, right? Furosemide is a very potent, causes a lot of urine production, and it could just lead to electrolyte depletion. Funny enough, look at that. We talked about that already. Contraindications. All of these diuretics seem to have some kind of connection with sulfa drugs. So that is something worth using as a blanket statement for all of these drugs. So please be careful and knowing about sulfa allergies for diuretics on at least loop, thiazide, and potassium sparing. Anuria, right? If they're not making urine, right, because the kidney has completely lost the ability, you probably wouldn't want to give this drug because it's going to make them want to make urine, but you're just in the end damaging the kidney. It's it to draw a connection, right? It's like when a person is they are what do you call it? They have constipation, right? And then you give them that Xylem, right? That bulk forming laxative, right? Ideally, it's supposed to help them go, but it could also cause them um, to like strain because now it causes more constipation, right? And that straining can cause a lot of damage if they were to have surgeries or something, right? So you're forcing the body to go when it can't, right? And then something bad will happen. I don't know what that bad thing will happen. Maybe your kidneys will just completely blow up or something, but that's why it's not good. If they're not making urine, you can't give them something to make it if they've completely lost the ability to. Or, I mean, anuria can also mean like a person who has an enlarged prostate, right? If they have an enlarged prostate, are they able to urinate regularly? Not really. And what if you just gave them a drug that's going to make them want to urine really, really bad? Because loop diuretics make you make a lot of urine. Now you're going to put them through a lot of pain. Hepatic coma and severe electrolyte or fluid depletion. Anytime you are to give this drug, and if there's electrolyte or fluid depletion, this must be addressed first. And makes sense, right? Because if you're going to make them pee a lot, then you're going to make them have much more, they're going to get more dehydrated and have less electrolytes, right? So hypokalemia is a big warning with Lasix, right? Given with digoxin, digoxin seems to cause a lot of problems with having low levels of potassium already as it is. So digoxin is already a hypokalemic agent, if we want to call it that. So with another hypokalemic agent, will cause more hypokalemia, right? They are not to be used with a lot of aminoglycosides, right? What are those? We talked about them. Mycins. It's a sin to give a mycin because they will kill your ear, right? So your ear will get affected, right? So you'll kill off the ear. And if this drug, this Lasix, already kind of does that, and you give it with another one that does it, then you're increasing the likelihood for it to happen, right? I highlighted the same way with these, right? Hypokalemia with corticosteroids and empiricitosin. Um, Lithium, you can have lithium toxicity because you won't urinate it out. And it seems like all of these diuretics diminish the ability of a lot of oral antidiabetics. So diuretics don't work with anti-diabetics. Maybe that's a rhyme we could come up with to help us remember, because they increase your blood sugar. They increase your blood sugar, they increase your BUN, they increase cholesterol, triglycerides, and electrolytes. So, or a couple serum electrolytes, right? So the thing that is most recurrent is our BUN, cholesterol, triglycerides, and increase in blood sugar. They all go up, right? That's something that all of them seem to do. So that's kind of nice to just have to remember that one time, and then that applies for all the other drugs, right? Hawthorne is a reoccurring one. Hawthorne, for some reason, is more hypotensive. So if you remember Hawthorne hypotensive with the diuretic, it makes more hypotension. And that's for all of the diuretics, which is again very nice because now that applies to all of them. Ginseng, on the other hand, decreases the effectiveness of the diuretics. So maybe we could come up with some kind of ginseng cancels out the diuretic, right? Hawthorne hypovolemia or Hawthorne hypotension with antidiuretics, but ginseng cancels out the antidiuretic. Um, and you probably wouldn't want to take a lot of sodium, right? Because if you're trying to prevent it, right, and we talked about it, you're on the same playing field, right? And then what if now sodium is higher than um than the drug, right? Now you're just pushing down on this and canceling out its effect. Treatment of overdose, right? If they're hypotensive, give them fluids, right? If they're low on fluids, give them fluids. If they're low on electrolytes, right? Where are electrolytes? In our fluids, give them fluids. If their blood pressure is that bad, you would give a vasopressor because, right, the diameter is pretty, like the diameter is right here, right? And then now it's right here, right? So, well, actually, let's pretend this is our normal vessel, right? Hold on, give me a second. All right, this is our normal vessel, and pretend all of it is full of blood, right, or fluid. But then it's now only halfway through, right? So now it's only this much because our blood pressure went down, right? We urinated too much. We would use a vasopressor, and then now in the same amount keeps a high level of pressure because we made the constriction occur at the vessel. That works for all of them. You give, it could be given if it's that bad, if the blood pressure is that bad, but for the most part, you're going to see fluid and electrolyte administration. Now we got our thiazides, right? Honestly, I'm going to skip a couple pieces of this because the indications are almost all the same. They're almost all, even the side effects are almost the same, right? They just picture the same side effects, just remove the ototoxicity from Lasix. And that's what thiazides do. I just want, the only difference is that it's not as effective as loop because we talked about it earlier. Because this one works later in the kidneys, right? It works right here. So there's not as much urine being produced down here. There is a lot over here because there's so much urine, right? So much of that salt held onto that water instead of being reabsorbed at the time. But it works so late that it doesn't make as much urine as it did, right? Like after all, like take a look at this. Look how much urine would be from here to here, right? Look at all that urine, right? Because sodium was prevented from being reabsorbed. But now only this much is really being made because sodium is being reabsorbed only right here. So from here on out, only that much urine is made instead of this much urine, right? So loop diuretic is down here, what I'm circling right now. It makes this much with it too. A thiazide diuretic only really makes this much amount. That's very less compared to the one if you add this much, right? Like as simple as it sounds, which one looks higher, right? The one that goes from here to here or the one that goes from here to here? That's why thiazides are very good. Actually, they're the most abundantly given diuretic because they're safer. They do cause a loss in sodium and potassium, mainly potassium and all that, but they don't cause as much as loop. Loop is a little bit more dangerous, right? But yeah, just more to highlight. Just they don't work as good, but they're, because if they don't work that good, then they don't work for severe renal failure, right? But they're really big for blood pressure. Um, a lot of patients will be on hydrochlorothiazide. I've seen that myself a couple times, right? The nice thing is Zide, right? Microzide, thiazide. Again, ascites is just referring to liver failure. Edema, it could be talking about the whole body. Liver failure is talking about liver failure. Nephrotic syndrome is talking about renal failure. And hypertension, again, is just a review from that. So, all with that. Prophylaxis for this part's a little unknown. We looked into this. I'm not really sure if it's saying you should take prophylaxis to prevent kidney stones, but I guess that's something to watch out with. But everything else is just review, right? You give in the day to prevent nocturia, makes sense, right? If you give it at night, they're gonna have to pee at night, so probably give it in the day. Adverse effects, right? Look at that. Electrolyte imbalances, excessive loss of sodium and potassium. Whoa, wow. Hypokalemia, we already talked about that. The only unique thing, right, is that it can cause gout because it makes the kidneys um, less excrete out urea, which high levels of urea will stay in the circulation and then cause gout, right? So what's unique about loop diuretic, right? We said ototoxicity. What's unique about thiazide diuretics? The cause of gout. Gout is unique. Hypokalemia and high loss of fluids, that's both. That we don't have to really fixate on. But what's very unique is the gout for thiazides and the ototoxicity for Lasix or our loop diuretic, right? Hey, look, there's that anuria again. Allergy to thiazides or sulfa, there's that sulfa again, right? And they are contraindicated for any woman who is pregnant and has high levels of hypertension due to the pregnancy, right? Um, right? They reduce the effectiveness of anticoagulants. Look, sulfonylureas, that's our anti-diabetic drug, right? So diuretics don't work with anti-diabetics, right? That sounds like a good rhyme. Here's that cholestyramine and cholestyramine, and I did put a little review, right? Um, cholestyramine and cholestyramine mess with the absorption of hydrochlorothiazide, and I put a little review for our lipids, right? You take meds 2 hours before or 4 hours after. You don't take them at the same time because the absorption, right? Because we said cholestyramine and cholestyramine are bile acid resins or sequestrants, right? So maybe something around here in hydrochlorothiazide has a little bit of, or not bile acid, sorry, um, fatty acid sequestrant, right? So It could be likely that they have a little bit of lipid in them, right? So maybe that messes with the absorption. Increased nephrotoxicity with NSAIDs, right? We already talked about that. NSAIDs are already a nephrotoxic drug. Hypokalemia with digoxin, right? There it is, digoxin again, reoccurring. Digoxin causes hypokalemia. And then carbamazepine causes toxicity, which that one came up prior before in a different drug. I'm kind of forgetting the name right now. Hydrochlorothiazide. So if you see this red box, this just basically means that it's really piggybacking off of a lot of the other drug lab tests, herbal food, and overdose, right? So to make it simple, right? Overdose, right? They're losing too much fluids. Look, there it is. Normal saline. You just give normal saline. Lose too much fluid, give fluids. Um, Increase in glucose, right? There's that glucose again. It goes up because it lowers the ability of anti-diabetic drugs. Increase in cholesterol, we already talked about it. Increase in triglycerides, we talked about it. Interesting enough, high levels of calcium could increase, right? Um, and then this is just generic. It lowers magnesium, potassium, sodium. Ginkgo causes high increase in blood pressure, right? So ginseng and ginkgo cause high levels of blood pressure, right? Two G's. Hawthorn, there's hawthorn again. It causes more low blood pressure. That's it, right? So we'll think like we'll be careful with the G's with diuretics. Ginseng and ginkgo. They cause higher blood pressure or cancel the diuretic out. Now we have our potassium sparing drug, right? Oh my goodness. Almost done. We're almost at the finish line. Don't worry. We're almost there. Spironolactone, right? That is our potassium sparing diuretic. They're the first drug of choice for patients of cirrhosis. That's the big thing that is very unique with it. Spironolactone, I want to emphasize, is the weakest of the diuretics. It is the least urine producing one because it works really, really late in the kidneys, like really super late, like all the way at the end almost, like pretty much finishing up over here. And all spironolactone does is it prevents the activity of aldosterone. Now, this is where I'm going to talk about the RAS a little bit, because this is kind of like a teaser for our heart meds, right? So, again, biggest indications, right, is giving for patients with cirrhosis, right? Here's that mild hypertension because it's not a very strong diuretic. It is used in combination with other antihypertensives. If I recall right, the book did talk about that it can be used with thiazide diuretics or loop diuretics to prevent the heavy loss of potassium. So that's something to watch out with. That's pretty cool that, this drug can be used with other drugs because this is kind of like a saver drug, right? But it's mainly saving potassium. Uh, as always, though, not everything is perfect, and sometimes we have danger that can come from this drug too. But we'll get into that in a little bit, right? So it treats mild hypertension. It treats edema associated with renal, liver failure, and heart failure. Surprise, surprise, we talked about those already before, right? If anything, just the hypertension. Loop would be for severe hypertension, while thiazide and potassium sparing would be for mild hypertension because they're not as strong. And then, right, if we said that this drug is a aldosterone inhibitor, right, it probably is given for hyperaldosterone in the blood or hyperaldosterone or like high levels of aldosterone production, right? So this is where I added this picture. I found it online. It helps a lot. I gave a first, second, third steps, fourth, and it helps me understand what's going on with aldosterone. This is very important for the RAS and understanding ACE inhibitors and understanding angiotensin receptor blockers. This is extremely important because if you understand this will help you understand those cardiac meds as well, right? So here we have renin, right? There's a initially we have a decrease in blood pressure, which will is mainly caused because of a decrease in and fluid volume, right? In the kidneys, we have this thing called renin. Renin is constantly on the lookout. It's constantly watching out, right? It's watching out for any loss of blood pressure. If that blood pressure is discovered, it activates this angiotensinogen. Remember oogenesis? Remember that from all the way in the beginning from friggin' anticoagulant drugs, right? That TPA, the tissue plasminogen activator. Here's angiotensinogen. So this is the predecessor to angiotensin 1. So renin with angiotensinogen, so plus, creates angiotensin 1, right? So this is step 1, this is step 2. Now we have angiotensin 1. When angiotensin 1 goes to the lungs, which is an interesting fun fact, all our ACE enzymes are in the lungs and they go with each other, right? So angiotensin 1 plus ACE equals angiotensin 2. This is our third step. Angiotensin 2 will create aldosterone secretion from the adrenal glands, right? From the cortex, or I'm sorry, from the medulla, if I recall right. Aldosterone then acts on the kidneys to reabsorb sodium in particular. Chloride will go with it, and water will go with it too, right? Because we said water likes sodium, right? Or salt. Angiotensin 2 activates aldosterone. Aldosterone acts on the kidneys to reabsorb sodium and water, right? So angiotensin has two functions: activation of aldosterone and activation of vasoconstriction. And look at this picture, right? So if we were to reabsorb water, right? We keep our fluid volume and we make the vessel smaller and increase pressure. What will that do to our pressure? And I just kind of put the answer right there. It's going to increase our blood pressure. This is what's going on. I did my best to color code it, highlight. This is the easiest, like, I know it looks complicated, but if you look at it, follow along, follow the pathway. I know it looks scary, but if you follow through and understand it just a little bit, you'll understand why. Because ACE inhibitors will prevent the creation of angiotensin 2. If you don't have angiotensin 2, you don't have aldosterone, you don't have vasoconstriction. ARBs specifically target the things that make this, right? So they do the same thing. They're doing it differently. Now moving back to our potassium sparing diuretic. Oh yeah, and it saves potassium because if you're not exchanging sodium in the kidneys with the because you're just constantly well, I'm kind of overcomplicating it a little bit, right? Let me kind of work my way back a little bit, right? So here's in the kidney, right? We said that in the kidney there's a heavy exchange of potassium with sodium, right? There's a big exchange. If you were to cancel out aldosterone, right, you're not reabsorbing sodium, you're not secreting potassium, right? Because if aldosterone isn't doing its job, you're not going to lose potassium because you're not swapping anything. You're just going to pee it out. That's what's occurring because aldosterone helps you retain your pee, I guess, if you want to call it that, or your urine or your blood or your water. If you shut off aldosterone, you'll pee out water. And with that, you're not really going to be losing potassium because potassium was never swapped for sodium. It does such a good job that you should not give potassium supplements because it actually does a very, very good job. You take with food to increase the absorption. And then here it is, like there's a high risk of hyperkalemia with potassium supplements. Makes sense, right? Because it saves potassium. Spironolactone saves potassium. We will say that. SP save potassium. ACE inhibitors, right? What did we just talk about? The RAS, right? If you shut off the ACE inhibitor, if you turn that off, you can't make aldosterone. If you don't make aldosterone, this is legit what this drug is doing. You're going to hang on to potassium, right? Because we talked about it earlier in the beginning, right? Potassium is swapped for sodium at the end when we make urine. In men, there's going to be weird hormonal stuff going on. Gynecomastia, which is basically breast development in men. Impotence, which is, well, I mean, it's impotence. And diminished libido, which is part of impotence. In women, they have menstrual irregularities. Unfortunately, I'm not too sure what this is. Heristium and or heuristism, but breast tenderness can occur, right? So one thing we can take away for the side effects, right? High levels of potassium, so hyperkalemia, and hormonal changes in men and women that cause issues, right? Two things. It's when you start to look like a guy. Oh. Hair growth on like your chin. Oh, okay. So this is hair growth on women, like excessive hair growth, where it's now in their face and stuff. Okay. Makes sense. Hormonal abnormalities. Black box warning. They have caused tumors in animals. I don't know why that's given, but it's just saying it should only be used if that necessary, right? So if the patient is losing that much potassium, okay, probably give it to them. But if it's okay, then probably don't give it to them because they have caused tumors in animals, right? There's anuria again, serious CKD, which is also pointing to anuria, right? Hyperkalemia, obviously, if the patient has high levels of potassium, would you give potassium? Basically, something that's going to hang on to their potassium? No. And then it's contraindicated for pregnancy and lactation. So, for the most part, it seems like all these diuretics are really not for pregnant. They're really not. Drug-drug interactions. Aspirin can increase potassium levels. Digoxin will decrease the effects of digoxin, right? Right, concurrent use. So again, it seems like digoxin works in its own way, um, in the sense that it lowers potassium, right? So or has a reliance on lowering potassium. So if you give something that has an increase in your potassium levels, then the effectiveness of digoxin will work. Which now we've been forming that pattern for like the past freaking couple hours here, right? Potassium supplements, ACE inhibitors, ARBs, hyperkalemia, and we went over that why it causes it. If you need to rewatch it, um, and if not, if it's a little left unclear, you can tell me and I can try to explain it a little more if you guys will need it. Concurrent use with other antihypertensives. I did not even highlight it because it's so obvious. If this drug that already causes you to kind of lose some urine, right? It lowers your blood pressure, and if you take it with other things that lower your blood pressure, they're going to lower your blood pressure. Finally, we have our lab values, right? They mess with glucose again. All these diuretics mess with glucose one way or another. They either increase your glucose levels or they mess with your lab results. This one increases cortisol levels. Now, why would it increase cortisol levels compared to the other ones, right? What did we say this drug is actively canceling out? It's canceling out aldosterone. What is aldosterone? It ends with "-one". We remember prednisone. We remember it's a steroid, right? What are we canceling out right here that says it can go up? Cortisol. That's the reason why our cortisol goes up, because if you're canceling out your natural corticosteroids that are in your body's going to freak out and try to make more to compensate why it's not there. There's Hawthorne again, right? Hypotensive Hawthorne. There we go. That's going to be like the saying we're going to use. Overdose treatment, fluid and electrolytes. That's it, right? These are miscellaneous. They have very specific and limited applications. They're not classified as the ones we talked about. The ones we talked about are the big three, right? The big three: thiazides, potassium sparing, and our loop. That's the big three. We only have two real limited applications for these other ones. Carbonic anhydrase inhibitors, known as acetazolamide, which is Diamox. It's in the name. It prevents the formation of carbonic acid, which helps a lot with lowering the issues with acid base imbalances, right? Because carbonic acid is one of the things we use when changing out CO2 in the blood. Well, like the moment it goes into the blood, if I recall right, it turns into carbonic acid, something of that like. But what we just need to know is this drug, this Dimox, right? Diamond in the eyes, we'll say that diamond in the eyes, they help with high levels of pressure for people with open angle glaucoma. Adverse effects, watch out with sulfa. Hey, look at that. All the other diuretics are all sulfa based, and fluid and electrolyte imbalances. That's so simple, straight up simple. But we can picture a diamond, this acetazolamide, a diamond in the eyes, and it helps us remember that we have high pressure. It helps us reduce the pressure in the eyes because of glaucoma. So that's our carbonic anhydrase inhibitor. And then we have our last one, osmotic diuretic, mannitol, osmitrol, which is nice because it has osmotic in the name, osmitrol. This one also inhibits carbonic anhydrase, but it does a different job. It reduces intracranial pressure due to cerebral edema, and it's mainly only for that. It's also used to maintain a urine flow for prolonged surgery, acute renal failure, or severe renal hyperperfusion, because the way it works is it's using osmosis to pull water to it. So if you constantly use have you guys ever seen that funny picture of a surge protector with the surge protector going into itself, and now you have unlimited energy? That's kind of what this is doing. It's constantly trying to make all this water catch up to here. And it won't ever do it because it's over here, and all that water wants to get here, but it just can't be fast enough. So as you're constantly using osmosis, which would make it hypertonic, it reduces the intracranial pressure because it takes it from the tissues, right? Pretend this is the brain. Pretend this is the blood vessel, so it's going into here. So it's reducing that edema. And that's it for diuretics. Um, Again, you guys, if things are unclear, because I know things are a little more complicated in this one, you guys can reach out and I can explain it a little better. But for brevity, this video is probably super long as it is, so I think that's enough for what it is. But again, feel free to reach out. Again, big help with everybody making the grids, making the pictures, making the videos, and everything else. We're all tired. We're all very tired, but we're trying our best out here. So that's all. Thank you guys for watching. And again, reach out if something is unclear.